Hello folks, welcome to our lecture on the endocrine system. This is looking at hormones and the glands that make hormones. You should see a lot of overlap between this and other systems that we've talked about, especially the reproductive system lectures that you just completed. These are our objectives for the lecture. This is what you should be focusing on to prepare for the quiz. So hormones are self-regulating. This means they can turn on their production and turn off their production. Hormones control how much of themselves they are making. Hormones are made in really small amounts, and as such, they're incredibly potent. They're very, very strong. They have to be very strong. If we're taking a very small amount of hormone and putting it into the blood, it's going to be significantly diluted, so it needs to be strong to compensate for that dilution. There is not one thing in the body that hormones do not affect. They affect your growth, your metabolism, your development, different types of behavior. They help with maintaining homeostasis in the body. They affect reproductive activity. We saw that in the last two lectures. Hormones are incredibly comprehensive. There are two different types of hormones, steroids and hormones that come from amino acids. Steroid hormones, when we hear the word steroid, what do you usually think of? Some disgraced athlete crying on national television? That's one example of a steroid hormone, anabolic steroids that help to bulk up muscle. But when we talk about steroid hormones in the endocrine system, we are talking about hormones that are made from fat. And generally the fat in question is cholesterol. Yes, you do need cholesterol in your body. You need it specifically so that you can make your steroid hormones. Examples of steroid hormones in the body would be things like your sex hormones, estrogen, progesterone, testosterone. Aldosterone helps with your salt and water balance in your body. Cortisol is your long-term stress hormone. These are all hormones that are made from cholesterol. They last a lot longer in your body than hormones that are made from amino acids, and they enact changes in your body that last for a longer time than hormones that come from amino acids. So hormones that come from amino acids can look like two different things. They can either be one amino acid that we take and tweak a little bit to turn it into a hormone, and examples of this would be things like epinephrine, also called adrenaline, melatonin, thyroxine, anything that ends in INE. We've just taken one amino acid and made a couple little changes to it. We can also have protein hormones, which are multiple amino acids strung together to make a protein. These would be things like insulin, growth hormone, oxytocin, which we talked about a lot in the female reproductive system lecture. Those are all examples of protein hormones. As I mentioned earlier, protein hormones do not last as long in the body as steroid hormones, and the changes that protein hormones make in the body don't last as long as steroid hormones do. But they also don't take as much energy to make, so we can very easily make more of them, whereas it takes a lot of energy to make a steroid hormone. Hormones work in feedback loops. This is the way that they are self-regulating. And feedback loops can be both positive and negative. I really like this example right here. If you're standing out in a field and suddenly a cow starts running at you, there's like a herd of cows in the distance and one of the cows starts running at you, you're probably going to get a little jittery, but you might not panic. But maybe, I don't know, maybe you start running a little bit and then that spooks another cow. So another cow starts running at you and now you run even faster. And now that's scaring more and more cattle and you have more cattle running at you. And now you're running and screaming and flailing your arms and that panics the cattle even more. And this builds and builds and builds until, I don't know, the cows run you over or you find a fence and get over the fence or something like that. That's an example of a positive feedback loop. Much more common than a positive feedback loop is a negative feedback loop. We see these a lot in our hormone systems in the body, and I really like this example that we have right here. So let's imagine, think back to that crazy bomb cyclone that we had last year in March. You have to go outside in the bomb cyclone. Mom wants you to go outside and shovel snow. So you go outside and you get cold. You got nothing on but your jeans and a jacket and you're cold. That cold is going to tell your hypothalamus. Your hypothalamus will pick up on the cold. And the hypothalamus will then release this thyrotropin-releasing hormone. Thyrotropin-releasing hormone will go to your anterior pituitary and tell your anterior pituitary to release thyrotropin. That thyrotropin will then go to your thyroid gland and tell your thyroid gland to release thyroxine, which is one of our thyroid hormones. That thyroxine will increase your metabolism, will also increase your body temperature and help you to warm back up as you're out there in the cold and the blizzard shoveling the snow. Now, when we get enough thyroxine, that will also come back here and tell the anterior pituitary, okay, we're good, and we'll shut off the anterior pituitary so that we don't make any more thyroxine because we got as much as we need. This is why it's called negative feedback. Presence of the hormone shuts down production of the hormone. Now, eventually, you will use up all of your thyroxine, especially if you stay out in the cold for a very long time. And when that happens, this pathway will open up again because you won't have any more negative feedback because you won't have any more thyroxine. So that is how this pathway turns itself on and off. A positive feedback loop, like what we just saw with you getting trampled by the cows in the field, we only see these in a couple places in the body. One of these is oxytocin during labor and delivery that we talked about earlier when we talked about the female reproductive system. So when that baby is fully grown and ready to be delivered, it's putting a lot of pressure on the cervix. The baby's head's pushing on the cervix, and that triggers release of oxytocin from the pituitary, and that oxytocin causes contractions of the uterus. And those contractions of the uterus push the baby's head against the cervix, and that triggers release of oxytocin again, which causes contractions which push the baby's head against the cervix, and this continues to build. So in this case of positive feedback, presence of the hormone will eventually cause more hormone to show up. Whereas with negative feedback, when you had the hormone shut off production of itself. The other example where we saw positive feedback, and this is one of the few examples that we see positive feedback in the body, was prolactin. Prolactin is the hormone that triggers milk production. So mom nurses her baby, and that nursing stimulates prolactin in the brain. That prolactin causes mom to make more milk. And then mom nurses the baby, which stimulates prolactin to be made, which makes more milk for the baby. And then mom nurses again, and this continues over and over until mom finally stops nursing until the baby is weaned. Positive feedback loops are very rare in the body because you have to have some kind of outside force act on the feedback loop in order to stop it. Usually the feedback loop of choice is a negative feedback loop. So here are your endocrine glands scattered all over the body. You can see we have a few up in the brain, we have a few in the throat and in the chest. We've got a few down in the abdomen. We've got ones down in the pelvic cavity. This doesn't look like other systems that we've seen previously. Think about the cardiovascular system, for example. The heart and the blood vessels, they're all connected with each other. Or the skeleton, that's all connected with each other. But our endocrine glands, not so much. So what is connecting all of these glands together? How do we get stuff from, say, the pituitary up in the brain all the way down to the ovaries or the testes or the pancreas? These are all connected by blood vessels. That's how we're moving hormones back and forth between organs. So you can kind of think of your cardiovascular system as sort of a minor player in your endocrine system, because if that's not functioning properly, you won't be able to move hormones throughout the body. The pituitary is also called the master gland of the endocrine system. The pituitary runs the show. Sometimes you'll hear him called the hypophysis. This is an older term. It's not quite as commonly used anymore. The pituitary sits at the base of the brain, in the front of the brain, this little guy right here, and is divided into two lobes, an anterior and a posterior lobe. The anterior lobe produces 6 hormones. The posterior lobe only makes 2. The anterior pituitary makes a flat pig. This is how we remember the names of our hormones that come from the anterior pituitary. So FSH and LH, which we saw in the reproductive system lectures. FSH triggers production of gametes. LH triggers release of gametes. ACTH, which activates the adrenal glands. TSH, which activates the thyroid. Prolactin, which triggers milk production. The I doesn't stand for anything. The I is just there because otherwise we'd have a flat pig instead of a flat pig. And then the G is GH, growth hormone. Those are our 6 anterior pituitary hormones. From the posterior pituitary, we get 2. We get oxytocin, which we've seen a lot already, and we also get ADH or vasopressin. He has 2 names. ADH helps with salt and water balance in the body. So those are our 8 hormones from the pituitary. Going down from the brain to the neck, you find your thyroid gland. The thyroid gland has 2 lobes. It almost looks like a butterfly. You sometimes hear people call it the butterfly gland. 2 lobes with a little isthmus that connects the 2 of them. And it sits on either side of the larynx and the trachea. And it makes hormones that affect metabolism and growth and kind of affects the way that your cells work in your body. And these are T4, which is thyroxine, and T3, which is triiodothyronine. The 3 and 4 in T3 and T4 indicate how many molecules of iodine you need in order to make each hormone. T4 needs 3 molecules of iodine, T3 needs 3, or T4 needs 4, T4 needs 3 molecules of iodine. Sorry. Where do we get iodine? Usually my students are like, food, which is true. We get iodine from food, but what food in particular? At least in the States. In the US, we get our iodine mostly from salt. Take a minute, pause the lecture, go run upstairs, find your big salt container. It should say at the bottom, this contains iodine, a necessary element. Iodine's added to salt. You can also get it from seafood, fish, shellfish, seaweed, that sort of thing. But we add it to salt just to ensure that everybody's getting the iodine that they need in their diet in order for the thyroid gland to function properly. We'll talk a little bit about what happens when you don't have enough iodine when the thyroid gland isn't working properly. The other hormone that the thyroid gland makes is calcitonin. Calcitonin decreases the calcium in your blood. It takes calcium from your blood and puts it into your bones. Now, if we were to take the thyroid gland, our little thyroid gland here, and flip it around, on the back side of each lobe, you'd see 4 to 6 tiny little pea-shaped, pea-sized glands. They're very, very small. And these are called the parathyroid glands. The parathyroid glands make parathyroid hormone. And parathyroid hormone does just the opposite of calcitonin. So calcitonin puts calcium into your bloods, puts calcium into your bones, sorry. Parathyroid hormone increases your blood calcium by pulling calcium out of your bones and putting it in the blood instead. This is useful for things like if you have low calcium levels and your muscles aren't functioning correctly, we can pull calcium out of your bones and put it into your blood. Or maybe you broke a bone and now you need a whole bunch of extra calcium. We can pull calcium out of the bones that haven't been broken and use that to repair the one that has been broken. So here's your thyroid gland wrapped around the trachea right here. You can see the two lobes and then this little isthmus in between that joins the two of them. And then on the back of the thyroid gland, here are your 4 little tiny parathyroid glands. They're very, very small. Going down to the abdomen, we find the adrenal glands. The adrenal glands sit on top of the kidneys. They're little pyramid, triangle-shaped glands. And they are stimulated, turned on to work by ACTH, adrenocorticotropic hormone. This comes from your anterior pituitary. There are 2 regions to the adrenal glands, just like there were 2 regions to each kidney. If you remember that from the urinary system lecture, you had an outer cortex and an inner medulla. That's true of the adrenals as well. The cortex makes cortisol, which is a steroid hormone. This is your long-term stress hormone. And it's there to keep you alive through very, very long-term stressful situations. And it's going to do that by interfering with things or interacting with things like blood pressure, your levels of blood sugar, inflammation in the body, memory formation, heart function in the body. What do we mean by long-term stress? What's long-term stress? You listening to this lecture? I mean, maybe. By long-term stress, we mean something like, maybe your patient lives in poverty. That is a huge stressor. Right? They're constantly worrying about money and work and who's going to watch the kids and where is my next meal going to come from. Maybe you have a patient who lives in a war zone. Think about everything that's been going on with Syria for the last, so many years. Or maybe your patient's out of the war zone. Maybe they're living in a refugee camp somewhere. Maybe your patient is sick, is dealing with a chronic illness. Maybe your patient is worrying about somebody else who has a chronic illness, right? Mom's in ICU and has been for the last month with COVID. That would be a long-term stress situation. And cortisol exists to help get you through that long-term stress situation. Now, the concern here is if you are constantly in a state of high cortisol, not necessarily because you're actually in a long-term stress situation, just because you're constantly being stressed throughout the day, this can be very, very damaging on your immune system and on your heart because it interacts with inflammation in your body. So learning how to manage stress to keep cortisol levels low when you don't need them is very important. Other hormones that come from the outer cortex, aldosterone works with renin and angiotensin to affect your water and salt balance in your body, and by way of that, your blood pressure. And then you do see small amounts of sex hormones, testosterone, estrogen, progesterone, being made by the cortex as well. The inner medulla of the adrenal gland makes epinephrine, which you might recognize by his more common name, adrenaline. You know anybody who is an adrenaline junkie, this is the hormone that they're talking about. So cortisol does your short-term or your long-term stress. Adrenaline does short-term stress. You are walking down the hallway and all of a sudden your sister jumps out at you from behind a door and makes you scream. That's short-term stress. Or you are driving down the highway, minding your own business, only going 10 over the speed limit, and all of a sudden you see the police officer with the lights on behind you. That would be short-term stress, that sudden rush of panic that you feel. Adrenaline does things like increase your heart rate, increase your breathing, increase your blood pressure. This is not a hormone that's trying to get you through the stressful situation like cortisol is. This is a hormone that's trying to get you away from the stressful situation, your fight or flight hormone. If you guys remember the story from, was it earlier this year or last year, of the guy up in Fort Collins who was jogging along the trail near Horsetooth Reservoir and got attacked by a mountain lion and strangled the mountain lion to death with his bare hands. That's an example of short-term stress and of adrenaline working appropriately to keep you safe. What that we could all be that cool. So here are your adrenal glands sitting on top of your kidneys, little kind of pyramid triangular glands. And you can see here this outer cortex and then the inner medulla that are making two very different types of hormones. The word adrenal means above the kidney. Ad means on top of or above. And then renal that we see there, you should recognize from the urinary system lecture. Renal just means kidney. The pancreas makes two hormones of interest. One is insulin, one is glucagon. Insulin's usually the one that you think about because this is the one that you see issues with in a patient who has diabetes. Insulin is, you can think of it as the key that unlocks your cells. Right, here's your little cell right here. This allows sugar to go into your cells so your cells can use it for energy. This is going to decrease the sugar in your blood because all that sugar is going into your cells. Glucagon then does just the opposite. Glucagon locks your cells so that sugar can't go into them. And this is going to serve to raise your blood sugar so that you always have nice, stable, even level of blood sugar. We will talk about what goes wrong with insulin and diabetes in a little bit towards the end of the lecture. Here's your pancreas right here. We call the cells that make insulin and glucagon your little islet cells because they're kind of look like little islands floating in the middle of your pancreas. Beta cells make insulin, alpha cells make glucagon. Other endocrine organs that we see, the pineal gland is found in the brain. The pineal gland makes melatonin. And you've probably seen like the bottle of melatonin for sale in the King Soopers or the Walmart or the Whole Foods, if you're bougie. Melatonin is a hormone that does a lot of stuff in the body. It plays a role in regulating your mood, in regulating daily rhythms, what we call your circadian rhythms. You probably notice that throughout the day, at certain times of day, you feel really awake and energized and alert, and other times of the day, you feel kind of quiet or drowsy or lethargic or maybe even like you need to take a nap. And that's all controlled by melatonin, when you feel very awake and when you feel maybe a little less alert. Melatonin also plays a role in sexual development, especially in animals that have a set breeding season. If you think about, for example, the elk up in Estes Park that breed in the fall, melatonin plays a role in bringing them into that breeding season. All of this that melatonin does is done in response to light. Ideally sunlight. Melatonin, when you look at sunlight or when you go outside and you're exposed to sunlight and that sunlight enters your eye, that's going to tell the pineal gland that it's day. Now, sunlight is not the only thing that will tell the pineal gland it's day. The other thing that will play a role in melatonin making or not making melatonin is also your blue light from your screens. And you've probably heard this because this has been a big topic in the news for the past 2 or 3 years. Think about when it's the middle of the night and you're lying in bed, I don't know, fighting with someone on Twitter or swiping through Tinder, or I don't know what you do on your phone. Or you're lying in bed yelling at Siri to set your alarm for the next day. Think about that bright, kind of eerie blue light coming off of the screen from your phone. Well, the wavelength of that light looks very similar to the wavelength of the light coming from the sun. And, at least according to your pineal gland, if we're being exposed to light that's basically the same thing as the sun, that means that the sun is up, that means that it's day, that means that we don't need any melatonin. Melatonin is made when you are in the dark, and you have to be in the dark for about 30 minutes before your pineal gland starts to really churn out melatonin. Well, if you are lying in bed, pretending to go to sleep, really getting in fights on Twitter, or texting people, or watching videos on TikTok, and not actually sleeping, the more you're exposing yourself to the blue light from the screen, the more you are shutting off your pineal gland, and the less melatonin your pineal gland is going to make, because according to your pineal gland, it's high noon because you're being exposed to so much blue light. So it's recommended that you do not expose yourself to any kind of light from screens, computer, television, tablet, phone, laptop, anything, for at least 2 hours before you go to bed. If you can't do that, then at least 30 minutes before you go to bed, but the less the better. We know that the more you're exposed to blue light before you go to sleep, the less you'll get sleep, the worse your sleep quality will be. It will take you longer to fall asleep. You will not get into the deep stages of sleep as easily. You will wake up more easily out of sleep and take longer to fall back asleep, and usually don't sleep as well rested as you would if you weren't exposed to that blue light from the screen. So make it a mission this week to, put that screen away so that you're not constantly nuking your pineal gland right before bed. Moving on, the thymus sits on top of the heart, over the heart and kind of the lungs in the chest, and it produces thymosin. We talked a little bit about the thymus gland when we talked about the immune system. Thymosin helps your T cells mature. These are the cells that kill off viruses in your body. The thymus gland is really, really big in unborn babies and in very young children. And then as you get older, it shrinks and gets smaller. And then the gonads we have talked about kind of ad nauseum in the last couple of lectures. The gonads produce sex hormones, either estrogen or progesterone if you're female, testosterone if you are male. Here's your pineal gland, this little guy right back here towards the back of the brain. It's, I guess, back center of the brain. The thymus gland you can see here, here's the thymus in a newborn. Look at how big it is. It's almost the size of a lung, sitting on top of the heart, on top of the lungs, on top of the trachea. As you get older, it shrinks. Some of the tissue is replaced with connective tissue, and it gets smaller. But like I said, very big in unborn babies and in young children. Prostaglandins are a type of hormones that are made by lots of different cells all over the body. And they play different roles. You have different types of prostaglandins. Some are responsible for starting uterine contractions. This would be something like prostaglandin F2 alpha, which primes the uterus to respond to oxytocin. Some of them do inflammatory response. So let's say you have an injury. You're outside gardening and you get cut on a rose bush. That damage to the tissue will cause the cells around that damaged area to release prostaglandins that will draw white blood cells to the area and fight off any bacteria that might get into that wound. And then vasomotor activity, this refers to dilating or constricting arteries. This is really important when you're trying to make sure that different parts of the body have adequate blood supply, or if it's very hot or very cold and you're trying to dilate or constrict arteries to heat up or cool parts of the body, there are prostaglandins that will tell those arteries to dilate or constrict. These are just some combining forms that go over what we've talked about earlier. Most of these should be fairly self-explanatory. Remember, hypophysis is another name for the pituitary gland. So occasionally you will see hypophysio as a combining form. It's not a word that's as commonly used as it used to be, but just be aware of it because you'll probably see it at least one point or another. The rest of these you can look at on your own, as well as the key terms. These should be very, very useful for your homework and studying for the quiz. So as you get older, you just don't make as much hormones as you used to. You don't make as much of them. You don't use them as well as you used to. Everything in the body slows down as you get older. You'll see increase in type 2 diabetes in patients because they're not making as much insulin as they used to. And you see this decrease in thyroid hormone, which will lead to issues like fatigue, dry skin, sometimes changes in memory. Thyroid hormone plays a big role in maintaining body temperature. So this is one of the reasons why grandma feels cold all the time, why it's 70 degrees and grandma's telling you, no, put on a sweater before you go out of the house. At my high school graduation, it was, gosh, like 98 degrees and we're all outside in our giant hefty bags and our caps. And we had a streaker run through the stadium at my high school graduation. And to the day he died, my grandmother talked about that nice young man at your graduation with the bullseye painted on his rear end. He must have been so cold out there without any clothes on, even though it was 98 degrees out. Anyway, so that's why grandma is always cold, because she has less thyroid hormone than you do. Some general stuff associated with the endocrine system and endocrine diseases. There's a lot of different things that can cause diseases of the endocrine system. You making too much of the hormone, you can make too little of the hormone. Maybe you're making the right amount of hormone, but you're releasing it at the wrong time. Or maybe the hormone is fine, it's just the organ that's supposed to respond to the hormone is not responding properly. You can also see issues with the hormone itself. So here's our cell. Every cell that responds to a certain hormone has a little receptor, either on the outside of the cell or the inside of the cell. We'll say this is on the outside of the cell. And that hormone should fit into that receptor like a little lock into a key. But here's our cell. If something goes wrong and our hormone is misshapen and doesn't fit into the receptor, that can cause endocrine diseases. Or maybe our cell, the receptor itself is misshapen and the hormone can't fit into it. So this would be like having the right key but the wrong lock, or the right lock but the wrong key. Or maybe both the hormone and the receptor are bad, and that's why you're having an endocrine disease or disorder. So you can imagine it takes a lot sometimes to diagnose a disease or an abnormality in the endocrine system. You can see issues in the actual endocrine gland. You can see issues in the hypothalamus or the pituitary, your two upstream glands that are making decisions about what happens when, that are not telling the hormone or not telling the gland to release the hormone that it needs to release. Maybe the pituitary is not making enough thyroid stimulating hormone, for example. So we'll look at some common aspects of the endocrine system. An adenoma in the pituitary gland usually causes this increase in growth hormone. Adenoma, suffix ad, or prefix adeno here, just refers to a gland. Do not confuse this with adreno, which refers specifically to the adrenal gland. So an adenoma is a tumor, that's what our suffix oma means, in a gland. In this case, we're talking about the pituitary gland, a pituitary adenoma. And like I said, this will usually cause increase in growth hormone. If you see this in children before puberty, this will cause gigantism. You just have a very, very tall person. If you see pituitary adenoma and high levels of growth hormone in an adult, you get this condition called acromegaly. Because after puberty, once your epiphyseal plates have fused to your bones, you're not going to grow any taller. Right? You're as tall as you get, and that's about it. So in adults, you see this thickening and increase in the density of the bones. And that's what we see in these pictures of our patient here. Here is a young man. Over on the left, he doesn't have any particularly striking features about him, but you can see the bones of the jaw, the bones of the forehead, the cheekbones just get kind of bigger and thicker and more pronounced as he gets older in response to this high level of growth hormone. Treatment for this pituitary adenoma, you can do surgery to remove the tumor from the pituitary gland. That's a pretty easy surgical treatment. There are also medications that will reduce the amount of growth hormone in the blood. So here we see two examples of gigantism. This guy on the left here, I don't know how tall these women are. I'm assuming they're just kind of average height. So he's got at least 2, maybe 2.5 feet above them. So he also turned into like a Viking warrior god, I guess, is what's going on there. This guy on the right here is, I believe, Yao Ming. He's one of the tallest basketball players that we have right now. He's something like 7.5 feet tall. Look at the guy hanging on to him on the right. I love this picture. He looks like a little puppy trying to grab him. Look at the size of his hand on the basketball. This guy is terrifying. This is another example of gigantism. And then if you guys are familiar at all with the movie The Princess Bride, with Andre the Giant in The Princess Bride, he had both gigantism and acromegaly. He had a pituitary tumor that just led to very high levels of growth hormone. I'll post a little clip of him and you'll see he's very tall. He's also something like 7.5 feet tall. And you'll also see acromegaly, the very, very pronounced bones of the face. Panhypopituitarism is just low functioning pituitary. And this can be caused either by a tumor or some kind of block to the blood supply of the pituitary gland. Think back to all of the hormones that we listed that came from the pituitary, our flat pig, and then vasopressin and oxytocin. You can imagine that this is going to affect a whole lot of stuff in the body. You'll see lots of goofy symptoms. This will also make it kind of difficult to diagnose what's going on since you have so many things that are affected. If you have a lack of ADH, low levels of ADH, which is antidiuretic hormone, also called vasopressin, you will see diabetes insipidus in your patient. This is not the diabetes that you're probably thinking of that affects your blood sugar levels and your pancreas. This has nothing to do with blood sugar and everything to do with how your water balance in your body is affected. So antidiuretic hormone makes you retain water. It keeps you from losing all of your water out of your urine. This is what helps you conserve water in the kidneys. If you have a patient who has diabetes insipidus, then they are not going to be able to conserve water and they're going to lose a lot of water in their urine. So one of the signs that you see of diabetes insipidus is polyuria. Poly means many, urea refers to urine, so literally many urine. Polyuria just means a patient who pees a lot. They're peeing out a lot of water. And if your patient is constantly peeing out all of their water, they're going to be very, very thirsty. So that's the other sign that you're going to see with diabetes insipidus is polydipsia, being very thirsty. Again, this is not the same as diabetes mellitus. This does not affect your blood sugar levels. This is not affected by your pancreas or by insulin. This is an entirely different type of diabetes. The word diabetes just comes from the Greek word for a siphon or a sieve. And diabetes just means that water is passing through your patient very rapidly. So in a patient who has diabetes insipidus or mellitus, you see polyuria. You see a patient who's peeing a lot of water. And that's where the word diabetes comes from. We'll look at diabetes mellitus towards the end of this lecture. Hypothyroidism is low levels of thyroid hormone. In adults, this is mostly kind of obnoxious and annoying. You'll see things like weight gain, feeling fatigued all the time, maybe feeling cold all the time. The skin can be kind of rough, dry, the hair is dry, sometimes falls out. Sometimes you'll see swelling of the face. Like, these are not pleasant symptoms, but they're not life-threatening. In infants, though, you'll sometimes see babies who are born with congenital hypothyroidism. They have some abnormality with the thyroid gland. In infants, this can be incredibly detrimental. You'll see issues with physical and mental retardation, profound physical and mental retardation. They won't grow like they should. They won't develop like they should. In the US, it's required to test all newborn babies for hypothyroidism to make sure that we catch that in time. And if that baby does have congenital hypothyroidism, you will give medication that will supplement those low levels of thyroid hormone. The other thing that can cause hypothyroidism in a baby, and we don't see this a lot in the US because we iodize our salt, is if this is a baby that's born in an area where there's not a lot of access to iodine. There's not a lot of iodine in the soil, and as such, they have very low levels of iodine in their body. That will lead to this hypothyroidism and then these very profound physical and mental effects that you'll see later on in life. There's a big public health kind of push and outreach to ensure that everybody around the world has access to iodized salt. And this is why we iodize salt, because it's very easy to put iodine in salt and because everybody uses salt. And you don't need a whole lot of iodine to get your daily required amount. So this is a big public health push to make sure everyone has access to iodized salt. You don't hear about it a lot. It's not sexy. It's not like saying I went and developed vaccines and brought them to, I don't know, outer Malawi. But it is really, really effective and a very cheap, easy way to prevent some profound issues later in life. So you can see this little baby right here in the picture who has hypothyroidism right here. And you can see the eyes are sort of sunken back. The face is very puffy. The tongue is protruding from the mouth. And then after treatment, our baby looks a lot better. The face is not as puffy. The eyes are not sunken, they're very bright, the tongue is not protruding. This has significantly helped our baby. Now, hyperthyroidism is too much thyroid hormone, and the most common form that we see is Graves' disease. This is an autoimmune disease where the body makes antibodies against the thyroid, and these antibodies trigger the thyroid to make lots and lots of thyroid hormone. Signs and symptoms that you'll see of Graves' disease, this will ramp up your patient's metabolism significantly. So usually you'll see weight loss, feeling hot all the time, lots of extra energy. Your patient will be kind of twitchy, maybe a little irritable. Sometimes you'll see tremors. Sometimes you'll see tachycardia, which is racing heart rate. And then the most noticeable, least forgettable sign of Graves' disease is this exophthalmos, bulging eyeballs. We'll take a look at that in a second. Treatment for Graves' disease is going to be antithyroid medication. You'll usually give your patient radioactive iodine, and that radioactive iodine will go to the thyroid gland and destroy the thyroid gland so that it's not making this excess of thyroid hormone. And then your patient will just be on thyroid medication for the rest of their life. This is a very common treatment for Graves' disease. Sometimes with Graves' disease, you will see a goiter as well, which is an enlarged kind of swelling of the thyroid. Normally, you should not be able to feel or see the thyroid. It's a fairly small gland. If you can see it or if you can feel it, something's gone wrong. So this is a good example of Graves' disease. Two things going on here. One, you can see the goiter here, this enlargement of the thyroid. And then they didn't tell her to just stare at the camera. These protruding eyeballs, this exophthalmos, just happens naturally with Graves' disease. There are 6 tiny little muscles that surround the eyeball that enable the eyeball to move back and forth in the socket in the skull. And in Graves' disease, the high level of thyroid hormone causes inflammation of those muscles, and that causes the eyeballs to push forward in the socket, and that's what causes this exophthalmos. Now, the good news is, with treatment of the Graves' disease, that exophthalmos should go away. The inflammation around the muscles of the eye will reduce, and the eyeballs will go back into the socket where they belong. But like I said, this is a classic sign of Graves' disease and kind of an unforgettable one as well. Looking at the parathyroids now on the back side of the thyroid gland, if you see overactivity of the parathyroids, usually this is caused by a tumor. They're going to make very high levels of parathyroid hormone, and that will give you very, very high levels of calcium in your blood. Remember, this calcium is coming from your bones. So we're leaching calcium out of the bones and putting it in the blood, and we're taking more than we need, which is going to lead to osteoporosis. This will also increase your risk of kidney stones, because now we have these really, really high levels of calcium in the blood. That calcium is going to be filtered out through the kidneys, but while we have very high levels of calcium in the kidneys, that increases your risk of developing rocks in the kidneys. Again, this is usually caused by a tumor, so treatment will mean going in and removing the affected parathyroid gland that has the tumor. After the tumor has been taken out, levels of parathyroid hormone should decrease back to normal, and then levels of calcium in the blood should drop back to normal, and that osteoporosis will be reversed. This is not the same as the osteoporosis that grandma gets when she's older just because she has weak bones. If the parathyroid glands are underactive, they're not making enough parathyroid hormone, then you'll have low calcium levels in the blood. And this is bad because you need calcium for your muscles to function properly. Calcium is what lets your muscles contract. So with low levels of calcium in the blood, you'll see sometimes tingling and numbness. Sometimes you'll see tetany, the muscles can't contract. You see this sometimes in dairy cattle. Dairy cattle that are bred to make lots and lots of milk. Sometimes they'll make so much milk that they deplete their calcium in their blood and they develop milk fever. Treatment for that is very simple. You'll just go give that cow a bag of calcium in their blood, and they'll be able to stand up and move again. There are 2 conditions that you see associated with the adrenal cortex in the adrenal gland. One is Addison disease, one is Cushing syndrome. Addison disease happens when the adrenal cortex isn't making enough hormones. This can be either autoimmune. For some reason you developed autoimmune disease against the adrenal cortex and destroyed that part of the adrenal cortex. It can also be you're not making enough ACTH in the pituitary gland. Signs that you'll see of Addison's disease: water loss, issues with blood pressure, issues with electrolytes, because your adrenal cortex makes aldosterone, and aldosterone helps with your salt and water balance in your body. So if you throw that off, you'll see weird issues with water and your electrolytes. And then because of that, you'll usually see issues with weakness. And then this symptom I think is really weird and really interesting, this increase in brown pigment in the skin. And that's what we see in our patient here on the right. You can see the gums here have become kind of brown and mottled, and the hand here, the skin, has become brown as well. Treatment for this will be giving those cortical hormones, especially aldosterone, to replace the hormones that aren't being made anymore. So that's Addison disease. The other disease that we see of the adrenal cortex is Cushing syndrome. And here we have too many adrenal hormones. This can be caused usually by a tumor, But you'll see this sometimes in people who have had to take a lot of steroid hormones. Sometimes you'll see this in people who did not have to take steroid hormones, who were taking steroid hormones as a performance-enhancing drug that will kind of jack up your adrenal glands. Signs and symptoms of Cushing's syndrome, these, much like Graves' disease, are kind of unforgettable. Once you see them, you'll never forget what they look like. So you'll see what they call a moon face, which is just a very, very round face. Increased weight gain, obesity, usually around the abdomen. You'll see kind of a hump of fat over the shoulders. They call it a buffalo hump. Weakness, hirsutism, which is increased hair growth, usually around the chin and the jaw. So think like male beard. And then fluid retention as well. So our patient right here, she has Cushing's syndrome. You can see the buffalo hump over the shoulders, the hirsutism, the hair on the chin and under the nose, the very round face, the hair on the scalp is starting to thin out. Now the good news is if you go in and remove the tumor that's causing the Cushing syndrome, all of these symptoms should go back to normal. All right, let's talk about the last of our hormone disorders, which is diabetes mellitus. This is the diabetes that you're thinking of when we talk about diabetes. Most common endocrine disorder, at least in the Western world. This happens when you're not using glucose properly, you're not using sugar properly. In your patient with diabetes mellitus, you'll see hyperglycemia, which is high levels of sugar in the blood. And because you have high levels of sugar in the blood, you're going to see glycosuria. Your patient's going to try and get rid of that extra sugar by putting it into the urine. And that increased sugar in the urine is going to cause increased urination, so you'll see that polyuria, like we saw with diabetes insipidus. So just like diabetes insipidus, your patient with polyuria is also going to be really thirsty, so they're going to have polydipsia. But then also, because they're not using sugar correctly, they're going to be very hungry because their cells aren't getting any energy, or they're not getting enough sugar for energy. And their cells are going to tell the rest of their body, hey, we don't have any energy, we're really hungry here, please go eat something. So even though your patient has very high sugar levels, they're still going to be hungry because their cells aren't getting that sugar in the cells where it belongs. It's getting filtered out through the kidneys instead. Okay, let's look at these two names, insipidus and mellitus, and see why are we talking about two different types of diabetes and what do they mean? So if you remember, I said diabetes just means a patient who's passing water. They're urinating a lot of water. And we have two types of diabetes, mellitus, which we just started looking at, and insipidus, which we talked about a little bit earlier. And these two words, mellitus and insipidus, give us an idea of what's going on with each type of diabetes. Let's start over here with insipidus. What does the word insipid mean? I say something is insipid. Oh, that was a really insipid meal, or that was a really insipid book or an insipid movie, or can't believe I have to talk to that guy. He's so insipid. What is insipid? Take a minute, pause the video, look it up on your phone, look it up on the Google. So something that is insipid is bland or tasteless or flavorless. And in this case, we'll see what we're referring to about bland or flavorless in a little bit. Mellitus over here, on the other hand, this comes from the Latin word or French word or Spanish word, miel. And miel means honey. So we have honey and we have something that's very, very bland. What are we referring to? Something that's sweet, something that's not sweet. So remember, your patient with diabetes, one of their key signs is polyuria. Either mellitus or insipidus, they're going to be peeing a lot because their water balance is thrown off for whatever reason. So does that give you an idea where we might be going with this idea of something that's insipid versus something that tastes like honey? So why does your patient with diabetes insipidus pee a lot? It's because they aren't making antidiuretic hormone And that antidiuretic hormone is what helps them retain water in their body. Since they're not making ADH, all of the water in their body is going to get flushed out through the kidneys. So they're going to have very watery urine that is insipid or has no taste. This contrasted with your patient who has diabetes mellitus, who also has polyuria, but they have polyuria because they have very high levels of sugar in the blood, and that sugar is getting flushed out in the urine. So they're going to have urine that has a lot of sugar in it or tastes like honey. And yes, I said taste, because once upon a time there was no such thing as a blood glucose meter. And the only way you could tell if your patient's diabetes was being properly monitored was to sample their urine and see, does it taste like honey, in which case we need to give them more insulin, or is it not sweet, which would mean their diabetes is being controlled properly. Usually my class loses their mind when we go over this part, because I guarantee it was not the doctor who had to sample your patient's urine. It was usually the poorly paid medical assistant who was doing that. So thank God for the glucose meter. But you know, if you're ever an MA in the zombie apocalypse, who knows, this knowledge might come in helpful. So that's where we get the difference between diabetes insipidus, right, where your patient is just peeing out all of their water because they can't retain it anymore, and diabetes mellitus, where your patient is peeing out all their water because they're trying to get rid of the excess sugar in the blood. If this does not make sense, drop by office hours. We can talk about it even further. So diabetes insipidus, this is low ADH levels, can't retain water. Remember, this is nothing to do with sugar or your pancreas or insulin. That's all over here on the other side with our diabetes mellitus. So high levels of sugar in the blood, what we would call hyperglycemia, sugar in urine to decrease blood sugar, to get rid of all that extra blood sugar. Now, there are two types of diabetes mellitus. We have type 1 diabetes mellitus, which is what you sometimes hear called juvenile onset diabetes. You usually see this in younger children. And then you have type 2 diabetes mellitus, which is the one that they call adult onset diabetes. This is the two types of diabetes that you usually think of when you think of two kinds of diabetes, the two types of diabetes mellitus. So let's look at both of those. Type 1 diabetes mellitus, or juvenile onset diabetes mellitus, happens when the pancreas stops making insulin for whatever reason. Generally speaking, this is autoimmune. The body starts attacking the little beta islet cells in the pancreas. They stop making insulin, and now your patient has very high levels of blood sugar, and they can't get sugar into their cells for their cells to work properly. You'll diagnose this by measuring levels of sugar in the blood while your patient is fasting usually. You'll do an oral glucose tolerance test, which is giving them a very, very sugary drink and then measuring their blood sugar to see how they're using that. Treatment for type 1 diabetes, you have to become your own pancreas because your pancreas has failed. So you're going to monitor your blood sugar levels, pay attention to how high or low they are, and give yourself insulin as you need it after each meal and anytime that your blood sugar gets high. And that insulin, you're replacing the insulin that would normally come from the pancreas. You'll also need to pay close attention to your diet and see how much sugar is in what you're eating so you know how much insulin you need to give yourself. There is currently no reversal for type 1 diabetes. There are some treatments in research right now that look very, very promising, but as of right now, if you have type 1 diabetes, you're going to be giving yourself insulin for the rest of your life. Type 1 diabetes is called juvenile onset diabetes because it usually shows up in children and teenagers. Usually you'll see like average age of diagnosis 10 to 14-ish or so, though I have seen reports of type 1 diabetes in like a 2-year-old child up to a 30-year-old adult who suddenly developed type 1 diabetes. That's very rare. The cause behind the autoimmune failure is not well understood. Right now, the hypothesis is that for whatever reason, you get some kind of viral infection, and that virus gets into the cells in the pancreas and causes the cells in the pancreas to mutate so that now the body doesn't recognize those cells as itself. It sees them as foreign. This hypothesis, I think, has a lot of promise behind it because there have been studies where you take white blood cells out of a patient with type 1 diabetes, you train them to not attack the cells in the pancreas, and then you grow a bunch of them and you put them back into the body, and they don't go after the pancreas, they leave it alone, and your patient with type 1 diabetes can start making their own insulin again. So that does seem like a very promising hypothesis, but so far there is no treatment. And unfortunately, the pancreas is one of those organs that doesn't transplant very well. Some organs do really well in transplant, kidneys and liver especially. The pancreas doesn't like to leave home. So it's very, very hard to take a pancreas out of your patient and put it, or out of a donor and put it into your patient. That usually doesn't end well, unfortunately. Now, type 2 diabetes mellitus, this is what you commonly call adult onset diabetes mellitus. It does have a small genetic component, but most of this is lifestyle that can be addressed, and if caught soon enough, you can actually reverse type 2 diabetes, whereas you can't really reverse type 1 DM. In type 2 diabetes, the pancreas still makes insulin, but the cells don't respond to it anymore because you always have very high levels of insulin, usually because your patient has a very high caloric intake. They always have a high level of calories that they're consuming throughout the day. You measure levels of sugar and diagnose type 2 diabetes the same way that you would diagnose type 1 diabetes. And like I said, a lot of this is due to poor diet, high levels of sugar, high levels of calories throughout the day, and with careful diet and exercise, it can often be reversed. There are also medications that will make the cells more receptive to insulin. You can also, if you need, give treatment to increase the amount of insulin that the pancreas is making to improve the way that the cells respond to insulin. Estimated that there's a very high population in the US who is pre-diabetic and doesn't know it. So making sure that you're regularly getting an A1C blood glucose check is a very good idea. Gestational diabetes mellitus is diabetes mellitus that occurs during pregnancy. Usually this is because of interactions between mom's hormones and the development of the placenta and the development of the baby. The good news about GDM is it usually goes away after delivery, but this needs to be monitored very carefully. And if mom does develop diabetes mellitus, she needs to be treated for it while she's pregnant. Because if she's not, then that baby has a very high risk of developing diabetes mellitus later in life. We know that babies who are born to moms with GDM will have a very high risk of developing type 2 diabetes later on. Metabolic syndrome, or syndrome X, is this hyperglycemia that you see along with type 2 diabetes, kind of a pre-diabetes. You see high levels of sugar, high levels of insulin resistance, weight gain, sometimes polycystic ovarian syndrome as well in women. Those can all be signs that your patient is going to develop diabetes. So that is it for the endocrine system. We have here at the very end of the slide a few pages with key terms. These are conditions or terms that we've talked about already. I would go over them in preparation for the quiz and while you're working on the homework. And as always, if you have any questions or would like to get further information about something we talked about, send me an email or drop by office hours.